Phase 3 trial of ibrutinib plus rituximab in Waldenström macroglobulinemia. Introduction. Waldenström macroglobulinemia, a rare form of B-cell lymphoma, is characterized by elevated serum levels of IgM and infiltrate of the bone marrow and other organs by IgM-producing clonal lymphoplasmatic cell. Treatment is commonly initiated in patients with the disease who have anemia, hyperviscosity, fatigue, or other constitutional signs.
Today in the morning, we talked about the biology of Waldenström macroglobulinemia and how much the biology has now affected both prognosis as well as treatment options. And that's very critical because now we know that MYD88 mutation is present in 90% of the patients with Waldenström. And that is so critical because it affects not only your prognosis of the patients, but it also affects the treatment options that we offer for our patients. The other mutation that's very critical is CXCR4 mutation. And again, that's present in 30% of the patients. And when we have both CXCR4 mutation and MYD88, that may again affect whether we use ibrutinib therapy or not in those patients. The other part that we talked about today, which was very critical, is 20% of our patients have familial Waldenström. And a year ago, we started looking at what are some of those germline mutations and germline sequencing that leads to potentially patients having familial disease. Again, it's very early in the discovery mode, but again, it's part of that idea of can we potentially screen patients for MGUS and smoldering Waldenström and can we be in the future predicting who will develop Waldenström or not? And can we prevent it from happening in those patients? And then finally, what I talked about is as we treat our patients with multiple therapies, whether it's proteasome inhibitors, alkylators, Rituxan, ibrutinib, we will have resistance and clonal evolution. So the question is, which mutations lead to that clonal progression? And we found in one of the studies that we presented in ASH last year that CXCR4 mutations increase significantly as we have progression post-therapy. So again, monitoring patients for clonal evolution during progression is very critical.
Application in medicine. Treatment rituximab with frequent use of immunotherapy to avert therapy-associated toxic events among those with disease recurrence. Innovate trial to evaluate the combination of ibrutinib and rituximab in patients with Waldenström macroglobulinemia, both among those who have received no previous treatment and among those who have disease recurrence with sensitivity and rituximab.
So this study is a follow-up in a group of 60-some patients with relapse refractory Waldenström's macroglobulinemia who had a median two previous treatments. 40% of them were in fact refractory to the last line of treatment. The median age was in the mid-60s. In terms of the IPSS Waldenström score, over half of them were either intermediate or high, and they were given ibrutinib, the standard dose, 420 milligrams per day. So they had an excellent overall response rate of about 90%, including a very good PR rate of 27%. And if you look at their baseline versus best response in terms of IgM, they went from roughly 35 grams to 8 grams. The percentage of bone marrow infiltration went from 60 to 20%. And hemoglobin, which was roughly 10.5 at the beginning of treatment, was about 14 grams by the end. What was also interesting in this study is that patients with genotype for mutations of both MYD88 as well as CXCR4. Mutations of MYD88 are known to cause upregulation in signaling through the BTK and hematopoietic cell kinase, and therefore render cells more dependent on that signaling and perhaps more responsive to ibrutinib. Whereas mutations of CXCR4 are associated with decreased effectiveness of ibrutinib in vitro. And so when they looked at this, it broke down the patients in three groups. Those patients who were mutated for MYD88 but had wild type CR4 versus those groups that had mutations of both genes.
Pros and cons. The combination of ibrutinib plus rituximab resulted in significantly better efficacy of the rituximab alone in producing rapid and durable responses with substantially longer duration of progression-free survival, both among patients who have received previous treatment and among those with recent disease. In the group of patients who received rituximab plus ibrutinib, there were reactions such as atrial fibrillation, muscular spasms, and neutropenia.
My name is Jorge Castillo, and I specialize in a very rare blood cancer called Waldenstrom's macroglobulinemia. When patients come to see me, I always encourage them to bring family members with them, friends, whoever they feel might serve as advocates. I think our approach in terms of taking care of the patient is that the patient and the families and us, we need to be part of the same team. And all of us need to be on the same page. And for that, they need to understand our thought process. And if they know very little about the disease, sometimes that's a little bit more difficult, actually. Waldenstrom's is a disease that patients will live with for decades. It's not the typical blood cancer that will translate into a death sentence or something like that. So we need to be very strategic, very mindful. We are not in the business of treating people. We're in the business of making people feel well. And we have always used hand-me-down drugs from other specialties, lymphoma, myeloma, into Waldenstrom's. But now we are at a place in which we can use those drugs with a very strong scientific rationale that why would they work in our little disease. And not only that, our laboratory is working on novel agents with novel mechanism of actions that are not seen anywhere, which will be very specific for Waldenstrom's. So I'm lucky, as a physician, to be able to be working in an environment that will allow me to, use the best medications out there, try to move away from chemotherapy, moving away from infusions and getting to treat our patients with these novel agents that are pills, kind of take 3 pills per day and then keep the doctor away and things like that, that will control the disease for years to come, and to try to bring our patients to a quality of life closest to what a normal quality of life would be.
Conclusions. In conclusion, the addiction of ibrutinib must rituximab presents a viable treatment approach for patients with Waldenström macroglobulinemia. But among those the who have received no previous therapy and among those with disease recurrence, regardless of prognostic or genotypic factor. Thank you.